Okay.
All right, we're about to go live.
Okay.
Just give it a couple of seconds to load up and we'll get started. Jackie, you just go ahead and keep letting people in.
I gotcha.
All right, we're about to go live. Oh, that's
Okay.
give it a couple of seconds to load up and we'll get started. My live was on. Anyways, welcome everyone. Thank you for joining us for another School of Global Health Management and Informatics webinar. My name is Katie Terry and I'm the Communications and PR representative for the school. I'm super excited to have you all and our guests here today. So before we begin, I need to play kind of like the flight attendant and get your quick attention to go over a few safety rules and regulations. So welcome aboard webinar flight 414 with nonstop engaging conversation. During your webinar, we ask that you please remain in your seats, seatbelts fastened, or at least keep your microphones muted. We will be taking questions from the audience during the open forum in about the last 10 to 15 minutes. During that time, we'll make use of the chat function or the hand raise function, which we can help you out with if you ask in the chat function to show you where those are. Please also remember that this is a live public event and to do your due diligence and keep your personal information protected. Emergency exits for most participants can be found at the bottom right-hand side of your screen, the little red button labeled Leave Meeting. For students flying with us on this webinar today, this is a UCF event, so all student code of conduct rules and regulations do apply. And the violations can result in disciplinary action or removal from the virtual aircraft. Additionally, any inappropriate behavior will not be tolerated and will result in removal from the webinar without a parachute. If you have any questions or concerns, please be sure to utilize the virtual call button or chat function, and message myself or Ms. Jackie Gonzalez privately. They can be found in that participants section. We'd be happy to help. Now, on to the main event. So today we are very, very lucky to have a couple of our great guests here for our talk on the transformative healthcare. I would first like to mention our esteemed faculty representative, Dr. Bernardo Ramirez. While I am the brilliant frontman, Dr. Ramirez is the real genius behind today's event and has graciously brought us into his classroom and his plans by sharing his guest speakers with us. So thank you and welcome, Dr. Ramirez. Speaking of, it is my absolute pleasure to introduce today's guests in no particular order. First, we have Daniel Peach and then Joshua Lopez. Both Danny and Josh come to us today from Advent Health, one of our largest internship partners in the Central Florida area. Danny is their Executive Director of Clinical Innovation, as well as a registered osteopath in the United Kingdom, where he also participates as a guest lecturer at osteopathic institutions. Danny will delight you with the extent of his experience, including co-authoring the book Transformative Healthcare, a physician-led prescription to save thousands of lives and millions of dollars. Josh comes, or I should say returns, to us as an alumni from our health administration programs. He is the Director of Strategic Programs for the corporate clinical team, collaborating with executives like Danny and leaders across the corporate functions, facilitating, coordinating, and implementing the clinical agenda. Over the past 10 years, he spent his time at Advent Health, touching clinical and non-clinical aspects of healthcare delivery, including publishing work in the Journal of Palliative Medicine. Danny, Josh, thank you for being here today. These wonderful guests did not come here to listen to me, so please take it away.
Katie, thank you. What can I say? Thank you, everyone, for taking some time out of your busy evenings to hopefully listen to us. I feel I should have brought my passport with me a little bit as I enter the aircraft, but we'll carry on. So thank you. What I'll do is I'll let Josh start off as the local alumni to be able to go through things. But before we really get into it, a couple of things. As any sort of lecture, any discussion that goes on, there is generally the need to give some data out. And there is obviously some data with healthcare that comes out. And unfortunately, it looks like the camera has decided to drop off on my computer at the moment. But look at what we do in the US and look at what we do in the UK. We measure a lot of things when we're looking at patient care. And one of the big things is always about the finance that's there. Now, capita, the US is about 17% of its GDP. It's about $10,000 per patient. Compare that with the UK, somewhere close to my heart, and that is around about $4,500. And that's about 10% of GDP. Think about that and now add that mortality age, the death rate that there is in the US. You're about 77 years of age, and it's about every 10 people in 1,000. In the UK, it's 81 years of age, and about 9.5, not sure where the half comes from, but 9.5 patients per 1,000. We spend a lot of money in the US. Do we get the care out of it? Do we get the balance? What we want to do is have a little discussion tonight. This is not that formal viewing that you would normally get. And what we want to try and do is bring out some of the changes we've been able to see and help happen within Advent Health, but hopefully in healthcare as a whole. Now, that's a journey to get there. And the way of getting there is ideally the way Josh got there. Josh, let us know how you moved through.
Sure. Thank you, Danny, and thank you to Katie and to Dr. Ramirez for having us on today. Just to give you a little bit of background, so yes, I am a fellow Knight, not too far removed. Graduated with my bachelor's in 2013 and master's in 2016. And since then, I've been working at Advent Health, initially in the clinical realm, and then that gradually evolved to kind of the administrative route. And so most currently, I'm working as a director of strategic programs for our Advent Health corporate clinical team, really helping to move forward the clinical agenda. But just to take you back to kind of where the starting point of where my passion initiated. And really, there were two things that were kind of the focal point while I was a student at UCF and was really cutting edge at the time. And I don't want to say back in my day because I don't want to date myself, so I'll let Danny do that. But yeah, so at UCF, the two kind of pressing topics were, number one, Obamacare, which that was really, the goal was to be able to address some of the access to care issues. And so with that and with the implementation of Obamacare, there really was a need for additional access to care, additional care coordination aspects. And so with that, there was a great deal of conversation, a great deal of initiatives to be able to implement that. Secondly was the triple aim. And so you may all be familiar with that. So being able to elevate the patient experience, being able to elevate the outcomes in terms of both from a quality standpoint, from a patient standpoint, and also being able to do that at an affordable cost. And so those two things paired together is really what kind of fueled my desire to go into like this cutting edge aspect of healthcare. And I learned about these two kind of big tsunamis as they were coming, and realized that I would have a greater impact in the community as a whole, as opposed to going the clinical route, which was, affecting one patient at a time. And so I really, my passion sits with being able to help healthcare organizations grow, develop, and being able to better coordinate care to make it a seamless experience for the patient. I would say probably the biggest, and if nothing else, please hold dear to kind of these words of wisdom. I would say that the biggest learning for me is to lean into many of the opportunities that you would experience as a master's student, or even an undergrad student. I would say that leaning into opportunities really helped form not just my work ethic and being able to move up the ladder, but also being able to frame kind of the work that needs to be done, and also frame kind of my experience and broad base in knowledge. So for example, being able to join student organizations, being able to go onto a mentor track, have someone that's available to support you and help you grow. And actually that's how I was able to start that administrative track. Also, I had the opportunity to study abroad with Dr. Ramirez. It was a wonderful experience and really opened my eyes to surveying international healthcare systems and being able to publish with Dr. Ramirez my findings in Eastern Europe was a great opportunity. Another short plug for Dr. Ramirez is, that study abroad trip happened about 5, 6, actually about 7 years ago now. And even still to this day, we work together on many of the tasks that need to be accomplished in the community, both from an academic standpoint, from a clinical standpoint at the hospital. So it's a great working relationship, and one that kind of spanned both the academic, my academic time at UCF, as well as my professional time working at Advent Health. And then the other thing I would say is really connect with the people that are sitting left and right on the virtual aircraft. I think it's hugely important to know that these eventually will be colleagues, these will be partners. In some cases, eventually, these will be my bosses. So please remember me. But yeah, so it's really important to be able to understand how they work, how they function, how you can best work together. Because the shift in healthcare is really leading towards breaking down those silos. And with that, Danny, I'm not sure if you have any comments to that or any words of wisdom. I know you've worked at the university level as well.
Yeah, I didn't know if we had any time left after you went through everything that you've managed to do in the 12 and a half years that you've been working. So, but just to give you a little flash shot about me, because it's obviously any discussion is all about me. And I was born at an early age, and obviously, as people don't realize, and if you don't realize, I'm not actually local to the US. I come from the UK. There I practice sports medicine, which meant really I don't understand medicine unless someone is kicking a ball or catching a ball. But on top of that, what I did is I was actually the COO of several engineering companies as well. So I had this little bit of a different look at how healthcare operates, both from the clinical end of it, of actually having to get your hands dirty, but also from the business aspect of how do we tie things together and how do we make it function. And it's one of the important things now, as Josh has mentioned, that as the flight attendant is walking through and passing out the peanuts and the drinks, is to look over at those people that are with you, because you're all moving in the same direction. And you've got to gather all of those experiences as you go through. And every aspect of my progress in career has been about gathering that information and adding that together to culminate pretty much into the job I'm doing now. Now, this enabled me to do some lecturing at medical schools in the UK in various areas. And all of that adds up to this one point of being able to speak to you all at UCF. Now, it goes a little beyond that. But the good thing is that that history, that knowledge allows us to be able to give on, to pass on that's there. And so the aim of this is to really start to look at transformative healthcare. How do we go from those ideas that you have to that implementation? Now, I can guarantee every single one of you has a bright idea. The trouble is, what it often does is it vanishes, it goes by the wayside. And what we want to try to do between Josh and I is to show you that be brave. Join with the people that are here and start to move forward. So, where do we start? Well, this whole trip started with Advent Health about 7 years ago. And the format that we looked at about trying to transform healthcare really came out of Boston. There was a quite eminent pediatric cardiologist there, Jim Locke, who really thought that healthcare was getting a bad rap. There were lots of administrators that were deciding what the clinical aspects should be, and it just didn't tie in. There wasn't the communication, the liaison that was there. So he formulated the idea of sitting clinicians down round the table, making them check their personalities outside, and really start to look at the real work that was going on about how do we treat patients and what do we do with that. So they sat down and they formulated some plans, and they wanted some people to join in. And so Advent Health was one of those groups. And it was ourselves, Brigham Women's, Boston Children, and Sigrenska in Denmark. And the idea was to start to formulate a cohesive force that could start to bring about change, to design clinical algorithms, to look at the way healthcare went forward and start to influence that marketplace and bring some support to clinicians. Now, unfortunately, Boston didn't really see the way forward. And I think partly because it was a truly academic basis, it didn't quite see how it could make it extend into the business world, into the community, and into hospitals as a whole. But Advent Health had that vision. They allowed Josh and I, as the early members of the team, and a couple of others, to actually start to formulate this and come up with a structured plan about how we can make those changes and how we can go forward. And that was the main idea. That was the spark of inspiration, the influence that was put on, and the trust by leadership to allow us to actually do something that had never been done before, and to do it without any structure, to create something new, to be brave, and to step forward. So, the structure that we had. Josh, you were in early on this. What did you think? Where did you go with it?
It was very overwhelming. So Danny, just to expand on what you were saying there, in healthcare, we really value specialization, right? So we want that one surgeon, that one provider that can perform that 1 in a million case and perform it with the highest and best outcomes. And agreed, we do. But I think the bulk of the work lies in being able to have kind of that generalized scope of knowledge. And one of the things that we were challenged with early on, or especially myself, challenged with early on, is to have that broad base of knowledge. When we're building these clinical algorithms, it's more than the clinical aspect, right? So it's how do we build in the operations side of things? How do we build in the IT component of things, being able to properly staff and resource from an HR perspective. So there are really many layers that go into building a clinical algorithm outside of the clinical scope. And one of the things that we found hugely beneficial early on is that being able to better understand those scopes of work and being able to introduce them into those conversations early on proved that we were able to reduce some of the barriers very early. And that's true, I think, across healthcare in general, not just with the algorithms that we've developed. Is now we're shifting from kind of the specialized or what I often associate with siloed work, and really introducing collaboration, being able to work as a team towards an end goal. And that's really something that we had to embrace, and was something that was fairly new for the culture of not just this organization, but the culture of healthcare. Is and as we move forward and worked with these teams, the goal was ultimately to be able to have almost a smooth kind of exterior while we're running around in the background, 90 beats to the minute. To be able to make sure that all of the support resources and mechanisms were in place. Danny, was that kind of your experience as well?
Yeah, and I think it raised some important issues that are there. Is that you think about most industries, and you look at the industrial revolutions that have gone on, and how things change in industry as a whole, and then you look at medicine. And really, there's not much movement that's gone on. Yeah, we changed pharmaceuticals, but the structure and how we learn. There was a research paper that was generated up in Boston, in Harvard, and it was never really allowed to be published. And what it did is really looked at 80% of medicine is really what clinicians learn in the hospitals from each other, the way of how we do things, rather than from the actual books themselves, from evidence-based practice. And subsequent to that, about 2 years ago, there was a similar study that actually was published from the UK. And it really supported that we almost tend to make things up as we learn it, as we go along. And part of that is trying to focus in those silos. So medicine doesn't change quickly. And in order to do that, you've basically got to screw up the piece of paper with the structure you've got and start all over again, and start to look at a broader base. Now, that means the thinking has to be changed. Don't think analytically. Let's not keep looking at the individual parcels that are there, those individual silos. Start to spread that thought pattern. Start to spread and think synthetically. That synthetical type of thinking is a broad-based. It's the way clinicians tend to look at things. If you're an engineer and you're trying to build a bridge, then you add the maths up. You decide where the metalwork, where the bricks are going to go. You decide how the cables are going to help support it. And you do that in a linear fashion. Now, a clinician, when you walk in the room and say, hey, I've got something wrong with me, then the first thing that they're going to do, besides looking at the computer and tapping in, hey, here's another $200, thank you, is to be able to say, hang on, I've got to think about this. What is your blood pressure? What is your temperature? What's your red blood cell count? What's your white blood cell count? What did you eat this morning? How far did you walk? And all of these aspects are not thought out individually, they're put together. And from that, they start to draw the conclusions that are there. So we don't lay out our shop in one go. Here, you throw the dice onto the floor. You look at all of that at the same time and start to bring it together. Because if you change one item, it has an effect on the others. Thinking broadly, thinking in a generalistic view, enables you to start to adjust everything at once. So when we go in and we start to deal with an issue in the emergency room, it has a consequence further in. It may affect environmental services. It can affect HR. It can affect the inpatient domain. It can affect the PCPs when that patient is discharged afterwards. And so you have to think about the consequences of all of these. And if you do it one at a time, then all you're doing is increasing the problems as you go through. Josh.
Yeah, and just to add to that, Danny, I think bringing it back to kind of the health administration program, I used to think of the program really as a blessing and a curse. And Dr. Ramirez, we've talked about this, it's a blessing in the sense that, and this is probably a good time to maybe have any participants, if you'd like to, maybe put in the chat kind of what your goals are, if you're thinking more the health hospital route or home health route, long-term care. It'd be interesting to kind of see what the demographics are as far as upward track. But yeah, just to go on the blessing and the curse. So it was a blessing in the sense that whether you're going into hospital administration, nursing home administration, long-term care administration, and then as a deeper layer, the exposure to operations, to HR, to finance, to IT, to quality. Those were all kind of wrapped in a bow and at least given to you as a foundational understanding within the program. I would say it was also a curse because you were exposed to all of these different areas, operations, finance, and whatnot. So without having kind of a trail or a path that you want to follow, oftentimes it can get very muddy. And same with what we were able to do at Advent Health is that being able to kind of have that defined path really helped kind of bring everything into focus. And so if you don't know that now, that's fine. I'm not saying it's going to be a muddy path for you. What I'm saying is that I would encourage you to maybe get some exposure into these different areas if you haven't already. Be able to learn more about operations and where the overlap is with IT integration and interoperability, which also would integrate with IT and clinical systems, HR, finance. Start to find some areas of overlap. If you have mentors, great. If not, potentially reach out to working professionals in that area and try to better understand. I think, especially with trying to break down silos, the more expanded knowledge that you have in those areas, the more you'll be aware of what those goals are and what needs to be achieved and how best to go through those workflows to achieve them. And I think it's very similar when we look at clinical algorithms, is we know what the end goal is, but oftentimes our United States healthcare system becomes very complex for not just patients to navigate, but also the administrative side to navigate. And that was really a big barrier to be able to address. And I see that there's a survey up, so that would be great if we can get some feedback on that. But yes, I think that would be a great way to be able to better understand how we can go ahead and move forward. Would you agree with that, Danny?
No, I'm just kidding. So
completely off base.
So no. And Logan and Randy, thanks for putting your input in there. And it's nice to see that interaction in there, because it shows, yeah, hospitals, healthcare is a lot broader. Think of it bigger, looking at the patient. And that was the interesting thing with both of the comments that you've put out there. It's about the patient. And that's the important part of it. We tended to lose sight of, and often we start to get, and you see this in a lot of the education materials that you tend to go through, is that a lot of it will be based on how do we get the metrics right? How do we get the finances locked in there? Because it's left, the clinical side is left to the clinicians and the administrative side is left to the administrators. Now, the big problem is that there are two separate languages. Now, imagine the confusion I had, because now I've got to learn the clinician language in American, I've got to learn the administrator's language in American, and then I've generally got to translate everything I hear and see anyway. And that's the big part of the role that we decided we had to take as well. One of the barriers that's often not considered is, are we saying the same thing? Are we look at this differently? And this is what we've really got to start to look at, is translating the experiences that we've got, being able to learn how to be in HR, how to learn how to design a hospital environment that the patients want to go to and hang out in, and how to start to look at how the patients can be safe, and you can start to get those decent reviews about, hey, this is a place I want to go back to. Now, selling Advent Health, one of the big things that we look to try and achieve is to take care of our patients. That's what hospitals are about. That's what healthcare is about. And almost taking that cradle to grave and being able to give patients the absolute support that we can. Now, there's got to be a structure to that. We're thinking synthetically. We're looking at that broad spectrum that's there. Remember, I said that to start with, a lot of there isn't real hefty evidence with medicine, not as much as you thought. It's out there, but it's not used in clinical practice, because this is about dealing with human beings. And so part of what we try to do is then start to bring it together. And the way of bringing that together is to use what we termed an improvement triad. Now, that's three parts of it. I'm going to give you the first one, and then Josh is going to talk about this, one of the second ones, and we'll finish on obviously the third. So we looked at the evidence and consensus-based medicine. What is the clinical way of approaching problems? How do we start to do this using the evidence that's available, using evidence-based practice? What are the clinicians doing? So setting them down in the room, checking their egos and their personalities outside and saying, how do you do this? Now, you may have heard of what tends to be termed cookbook medicine. This is not that. This is not a case of if A plus B, you must do C. This is a case of starting to gather the evidence together and then finding out, is this what you do? And how do you do it? And how can we make it better? And where are the barriers? And bringing all of those elements together. Now, once we've got that, where do we go next? Josh?
Yeah, thank you. And Katie, I can actually share my screen here. It's disabling me. I have a graphic that can kind of highlight this thought process. It actually says disabled, so I'm not sure, but I can talk through it. So the second one is actually clinical outcomes. And so that's really where we want to better understand, both from a quality perspective and from a patient satisfaction standpoint, is the patient getting the right care in the right place at the right time? And so we have a group of metrics, not many, maybe a handful, to be able to better understand those outcomes. So that could be anywhere from, yes, there's length of stay involved in there, there is mortality in there, but we look at slightly different metrics around that. So one of the things that Danny can probably expand on better than I can is looking at deviations. So of course we know patients do weird and wonderful things. Physicians oftentimes do weird and wonderful things. But the idea behind that is but the idea behind that is, how can we capture that information and make it relevant to the work that we're doing? It may be a case of Dr. X is doing amazing work, deviating from an algorithm or a pathway in some instance, but is showing better results. Great. let's highlight that, let's tweak that a little bit so that we can include that as part of the algorithm. And now it becomes a more relevant, more up-to-date and ongoing evolving pathway. And we really bring that to life in keeping it at the forefront of everyone's minds. And that's really where clinical outcomes really need to drive, is being able to look at some of the subtle gray areas to better understand how we can improve.
So we go on from there. So we've got evidence and consensus-based medicine. We've got our clinical outcomes. So the last part of that is really the innovation. How do we put this together to make it work? So there are various processes that can be used to get it in place. But one of the things that we found really started to come up is disruptive innovation. This is the time you can really start to have fun. Because what you're going to do is change and make changes without anyone really realizing that it's happening. So let me give you an example. I'm old, been old for a long time. And the old part means that I grew up with a landline, a telephone that was actually attached to a cord. Thank you, Josh. And so whenever you needed to go to the phone, you either had to go into the home, grab hold of the phone, walk across the house and get half strangled by the cord that was attached to it. Or you go and find a phone box. Now, I know some of you may not know what a phone box is, but these were a box with a telephone in, and they were in strategic points. So what then happened is some bright spark said, hey, what about if we can walk around with these phones? They started to introduce cell phones. Everyone said, we're not going to use those. They're a newfangled invention. We won't use it. So everyone now look in front of them. Half of you are probably looking at this on their cell phone. Life has changed. It was a disruptive influence that came through. No one realized it was happening. It just transitioned. No one tends to have a landline in their home now. Everyone's got a cell phone. It's with them permanently. You look at it permanently. There has been that disruption to life and the way that we've looked at it. This is a little bit like going camping and boiling water up. You put the stove on the fire that you've built, you put your water in there, and then you stare at the water and nothing happens. Then you see a little bubble pop up and you still stare at it and nothing happens. So you say, I'm going to go and get some more sticks. The fire needs prodding up. You turn around, you walk back. Now when you get back, the water's boiled all over the place. It's out of control. That's the energy that's come from the fire. That's the energy that's come from the enthusiasm and the drive that you have for a project. That's the innovation. It then drives that energy through the water and transforms it. It changes it into steam. It makes it boil over. And it happens when no one realizes it's happening. That's part of that basis. That's part of the work that you can see with the works that come from people like Clay Christensen, and really show that in healthcare, there is a way of innovating from that disruptive influences that are there. That's the way of peaking it up. So now we've got the tribe. We know what we want to do. We sort of know how we want to accomplish it. We've got to come up with a methodology for that. So, Josh, I have no idea what to do with this. Do you reckon you know?
Not a clue, no. No, so this is actually what I think is kind of the bridge to implementation, right? So you have the idea, you have the framework of clinical outcomes, innovation, and evidence and consensus-based medicine. Now you have to implement that. And this is kind of the bridge between the two, is the methodology. And the team here, we really looked at a very specific targeted methodology. It's a 4-step cycle, starting with the design stage. And design, you can see, is the most elongated, and that's probably the most tedious process and the longest process throughout. And that's really where we're looking to identify what barriers exist to care. So being able to learn and look at opportunities where variations may exist. And with those variations, we really have to build consensus. And so Danny will often say that if you ask a clinician, what do you do? You'll get answer A. And if you go to clinician 2, you'll get same answer A, probably in a different format. You go to physician 3, again, you're going to get the same or similar kind of response. And so the idea is, if 80% of physicians and clinicians, nurses can agree, then we can, that's at least a good starting point to be able to build that algorithm. And what is that consensus based off of? It's evidence-based research, it's practice-based evidence. What are you currently doing? It's being able to look outside of your organization at regulatory requirements, being able to look at some of the measures that have been in place, whether they're new or existing, or maybe they need to be broken completely. And being able to get kind of that lay of the land before moving forward. That then goes into, now you have your algorithm on paper, you're ready to implement. Highly recommended that a pilot be done. And this is really where you work out the kinks. So Danny, you probably have a good analogy with this. I've heard it quite a few times with test driving a car here.
Yes, so, you know, with the pilot, this is one of the things I need to stress is we have this cycle of life that we term it, this methodology that's there. And the crushing urge of anyone is to jump from that. We've got it all designed. Let's go straight into it and let's try and get it working and running. Now, that's going to be fraught with failure. How many of you have bought a car? Sort of an open-ended question, but I think pretty much everyone has managed to do it at some stage or another. Now, that's not an easy process. You flag through the books, you look at what you fancy, you see it gliding past with big wheels, nice and shiny, and you think, no, the sound system in that is just the right level to blow old people's eardrums out. I want that one. And so you go to the dealer, you look at the car, you jump in, you take it for a test drive. And as you get around there, you say, you know what? No, this is the Three Bears type scenario. This car's not hot enough for me. And so you take it back in and you say, I want to take the other one. I want the bright red one with the big silver wheels on it. And you take that one out. And you say, actually, this one's a little too hot for me. So you bring it back and lo and behold, there's a Mini Clubman, the perfect car for you. You squeeze yourself into it. You drive it up the road and then you realize that you can park this thing anywhere you want in Orlando. So that's my one. That's the last of the Three Bears. That suits me. That's your pilot. We're going out and we're trialing it. We're seeing what's happening. We're getting a flavor. And more importantly, what we're able to do during the pilot is to find the deviations. Don't be rigid about it. Remember, we're thinking synthetically. We're pulling that together, finding the deviations and not chastising people for going off the path, but actually accelerating that need, that capability, and relishing in that change that can come about, putting that in and changing the algorithm, changing the thought process, changing the way of going forward in the pilot. Then you record the data. Now we've recorded it, we validate it. And then we move on to that implementation. How do we spread that out? And more importantly, how do we educate that? Gone are the good old days of using carrier pigeons, big books. Now what we can do is we can email this out. We can put memes out to try and mimic what we want people to achieve. We can write in hieroglyphics that I still don't understand, but we can still do that and get it out there. Then the last bit is Josh's favorite section.
Yeah, and just to comment on the implementation piece, that's really where you cross over from the idea to implementation. And really being able to have a vehicle to do that is going to be very important to advancing the work that you're doing. We use a change management methodology, and you may have learned about this throughout your course, but change management really refers to, it's kind of an overarching term to be able to refer to the support, the plans that you have in place, the resources that you have in place to be able to communicate and execute on what you're doing. And ultimately being able to use that change management strategy will help lead you to that sustain piece. Now, in that sustain piece, that's really where you want to build your infrastructure. So you want to make sure that you have your clinical outcomes in place and that you can benchmark if you need to. You want to make sure that you have your hardwiring in place so that if it needs to be part of the medical record or if it needs to be something that's integrated with technology, that you have a pretty firm foundation to be able to do that. And many of the different areas to be able to hardwire this into the system. But going back to change management, I think, and I'll advance the next slide here. So there was a I guess, a journal article that was published in the 1980s. Danny probably knows this one very well, but it covers change management. And the reason why I like this graphic is it kind of gives you a good formula. And so with that formula, it gives you all of the components to what is needed to execute on a change management strategy. That formula I kind of equate to an ingredients list, right? So if you're cooking, there's the ingredients section of the recipe, and then there's the actual recipe. So Danny will talk to or speak to the recipe that's there, but this kind of sets the ingredients list. And so vision is the first one, and it's very important to not only communicate the vision in a way that resonates with people, but also to inspire that vision so that people are bought into whatever it is that you're navigating through and trying to change. Without that vision, you're going to have a whole lot of confusion. Secondly is skills. You want to make sure that any subject matter experts, any champions of the change that you're doing, that they have the skills necessary to be able to get the work done. Without the skills available, it's going to cause a lot of anxiety and also can lose a lot of credibility in the work that you're doing. Next is incentive. And when we say incentive, it's not necessarily financial. There are other aspects to incentives. That can be outcomes. That can be patient experience. That can, in some cases, be recognition or wanting to publish the work that you're doing. It could be a regulatory requirement. So once that incentive is defined, it's very important to be able to work to that incentive and be able to communicate what that incentive would entail so that you don't have that resistance that's built up there. Next is resources. So having the availability and the support, having ongoing education, oftentimes being able to communicate things 5 to 7 times. How many, Danny? 5 to 7, 5 to 7, 5 to 7, 5 to 7. In order for that change to stick is going to be very important to being able to avoid some of the frustration that may exist when navigating through change. And
Josh,
lastly is action.
Josh, hang on a second. How many times?
I think it was 5 to 7.
Oh, okay, thank you.
But last is the action plan. And that's really where you would have the steps in place to march forward and be able to have the confidence in navigating through the unknown. And really without the action plan, that's where you experience false starts. That's where you have delays, you have setbacks. And so having a comprehensive action plan will help in navigating that change. So that's the ingredients list. And then I will switch over to the actual recipe.
So you all thought that you were actually here to learn something about healthcare administration. What we've actually got is a modified cooking class for everyone. So, but this actually works for everything. It does go through there. And so, yeah, we're at the recipe. This is the sexy end of, you know, what we're looking at. We've got the bare ingredients that are there, and we're going to actually construct something with it. And a lot of this is based on Kotter, John Kotter, and his outline of change management. And what we did is took that and then we tweaked that. A lot of times what we tend to do in healthcare is we look at change based upon industry. Now, in industry, you make widgets. Been there, made them. And if you've got a widget, what you want to do is make it cheaper. You want to make it faster. So what you do is you change the color, you reduce the materials, you buy cheaper products to be able to put it in place. That enables you to bring out a cheaper widget. Now, unfortunately, our widgets talk back. They don't want to be a different color. They don't want to be a different shape. They want all the bits still on them that they came in with. And so that means we have to adapt. We have to change what we do, not just with the patients and about getting them work through the system, but with our staff, with our clinicians, with our support staff that are there. We have to make that change that goes on. And so we had to change the change management of Kotter to be able to help and support it, to be able to look at this from a clinical point of view, from a transformative point of view in healthcare, rather than widget change. And so we go back to that cycle of life that you had, that design phase. And remember what Josh was talking about with Ambrose. We've got to get the right source in there before we can make it work out. So we've got to generate that sense of urgency there. We've got to bring together that guiding coalition. We've got to start to focus then, get a real deep vision and strategy of how we're going to get there. Now, importantly, this is about communication. It's about getting that change of vision over to everyone. And we've got to make sure that we talk the same language to get that over there. Now, more importantly, we've got to empower everyone. How many of you are working in healthcare already? And I've seen there's a few of you in the chat that you feel constrained. You feel, I know how to do this better. We've got to empower people to be able to stand up and say, hey, what about? And don't be afraid of failing at that. That's the big part of the design phase. Being able to break it and fail quick, get it resolved, get it moved on, and don't fear that failure, because that's the next step to success. Now we've got that, we go into that pilot phase. And with that, same as Cotter said, we've got to generate that short-term win. Let's get people excited. Let's get them going in the right direction. Now we're going to try and implement that. We're going to drive that into place, and we're going to consolidate the gains that we've made. That way we can generate, it becomes self-perpetuating. We generate more change out of that. We generate more excitement. We get more input from the empowerment that we've given everyone. People are starting to think synthetically. They're looking out of the box. They're bringing together all of those elements and conjoining them. Now we've got the grand basis we need. Now we're starting to cook on gas. And what we're going to do is we're going to end up getting that sustained phase. We can now anchor this in. We've got all the ingredients together. We've thrown them in the pot. And now we're going to come out with a product. We're going to come out with the best sandwich you've ever made that we're going to fry up. And we need to build up as many calories as we can in that so it can be as tasty as possible. So we bring in every herb, every spice we can lay our hands on and just cook it all together. Now that then starts to change our culture. We're mixing all of those herbs and spices of the individuals, of all the elements that we've taken together. And now we've cooked it into the tastiest sandwich you have ever seen or tasted. Now what we've got to do is we get it out there. Let's get it out on the plate for people to try. So we cut it up, they start eating it, and then they say, you know what? Maybe a little tweak of parsley in this one would have just set it up. So we continually gather that feedback. We continually put it together, and we really start to see the change. And then the biggest thing happens that we need to be aware of. It's about the sustainability. It's keeping it going, keeping the input there. Those that are data gatherers, those that love numbers, we need the numbers, but we need to keep generating it. That's not the be all and end all. This is a cycle. We keep moving around. We keep redesigning as we get new information in. As new herbs and spices are discovered, we put those into the sandwich. We try it. I don't like that. It's a bit like peanut butter and jelly to me. No, not quite my taste. But you keep trying it. You keep tweaking it. We start with peanut butter and jelly, and we end up with a cheese sandwich. That's fine. As long as we go through the methodology that's there, as long as we involve everyone, get that consensus, we get that energy and drive it forward. That in itself starts to provide the sustainability. Think about it. Use it. Josh.
Well, no, I was just going to go ahead and go on to the next graphic to kind of summarize. I know we're coming close to time, and I'd like to allow some time for questions. But yeah, so this is kind of the framework that we've developed for the better part of about 7 or 8 years now, and being able to roll out clinical pathways across the organization. I think, Danny, we're standing probably at about 30 to 35 different pathways, and that's across many different specialties, many different environments of care. And that number continues to grow. And often what we've seen is that there have been some intersection points there. And so now as we start to look at, I know Danny referenced chest pain earlier, you potentially have now expanded that criteria to other areas on the inpatient side and the emergency department side, on the outpatient side, to be able to better coordinate care across the system. And so I think that will be a huge value add to the organization and to the patient to not only promote better outcomes, but also have better or be able to set better expectations for patients right when they're walking through that door.
So it's interesting you brought up the chest pain. Well, it's not really, because we said we were going to talk about it. But just to give you an idea of the value of how the ideas can come out. So chest pain, the measurements that you have, patient presents to the emergency room. In Advent Health, there are about 25% of the patients who presented were then transitioned home again from the emergency room. And about 25% went to an inpatient domain. So that's a couple of days or more stay. And the rest were in an OBS or a cardiac unit care. Fast forward 7 years on, over 60% of patients are now transitioned home from the emergency room with chest pain in Advent Health. About 10% are going to an inpatient domain. What does that equate to? You're looking at over $30 million in one program that's changed the face of healthcare. You've taken that money out of the system because the patients don't need to be there. We can treat them better in an outpatient domain. But more importantly, we can create a vacuum in the hospitals. It equates to about 100 patients a day that we're going through. That's another hospital. We create the vacuum. Now what that allows us is to expand our footprint, to be able to bring in those patients that were outside of our network before, bring those in to take care of them in the best way possible, to be able to bring in patients who really need transplants, but because they're going to spend a long time in the hospitals, we need beds for it. There may be a pandemic that comes around and other hospitals are falling by the wayside because they have no beds available. But we can create the space by managing the way we look at our patient, by putting in a pathway that helps drive that, to look at ourselves and to translate the communication between each other so we start to speak the same language. This is about being brave enough to apply the capability, to look at the cycles that are there, to be able to generate that buzz. And more importantly, don't be afraid to fail. Do it. You can tell I came from a sports environment because I'm quoting Nike at the end of it. So get on with it. Let's move on and keep going.
Thank you, Danny. I'm not really sure what you were talking about. There were sandwiches, and then there was a vacuum, and then we ended with Nike. So somehow I'm hungry. I feel like I need to clean and go get some sneakers. So that was great. No, but I do want to go ahead and move into the Q&A session. You guys have talked about so much great stuff. To our participants, please utilize the chat function. You can do privately to myself or Ms. Gonzalez, and we can read it to the participants or our panelists, or you can put it in the everyone chat and we'll read it out. I'm going to throw the first curveball. Danny, you just mentioned COVID-19 coming into play when you're doing these types of things. So, that's my first question. As we've gone through this pandemic and what's changed, how has it impacted these cycles? And did it enforce the theories, or did it kind of show there were areas that needed to be improved?
Well, I'll take the first part and Josh can add if he wishes, because Josh has now got, through the hours and hours of endless work and support from Dr. Ramirez and all the education he got from UCF, you told me I had to put that plug in there. He's managed to move through the lofty levels and now is in a position where he's able to see that strategic view of what happens. But from the pathway side, we actually saw it reinforce the pathways because the clinicians, the support staff were in an environment where they trusted it. It was theirs, it was in place. And so in order to take care of patients, when we didn't really want patients in the hospital for fear of them being subjected to the pandemic, then it allowed the confidence to transition those patients into an outpatient domain to be cared for by their PCPs or by telehealth. What we have found from the pandemic, to our joy, is that it meant that change was expedited. As an organization, we went from not really understanding the conditions that we were under and being able to flip that both scientifically and logistically to be able to support the needs of the environment, of the area, and also to look at the different aspects that were there. You think we're not just dealing with sick patients, we're having to identify and test them. We're having to deal with those patients and learn new techniques and support ways of getting those patients as well, or keeping them alive as much as we can. And then also to look at how do we vaccinate the population? How do we get people involved in that and able to support the population in a massive scale that has never really been done in this country before? Josh?
Yeah, and just to add to that, I would agree. I think that this kind of COVID and 2020 in a nutshell really accelerated the work that we were doing. I think when we looked at many of the different areas, whether it be transmission or vaccination or clinical guidance as it was being updated almost on a daily basis, we really had to accelerate this methodology to keep it top of mind and relevant to the work that the team was doing. And so that posed a huge challenge, and accelerating that work really helped alleviate that. But the other side to that is being able to take care of our employees. And so across 40 plus different hospitals in 9 states, we really had to figure out a way that we could provide healing and protection to our team. We also had to find ways that we would be able to appropriately staff our teams so that they were adequately supported and being able to take care of patients. And we were also having to make sure that we were able to have accuracy in reporting, accuracy in vaccination, so that we were ensuring that the utmost safety of our staff. And working with our employee health team, we were really able to, again, accelerate this methodology to standardize care for our employees, which is one that eventually led to a bigger overhaul. But being able to understand initially and use this methodology started that conversation. So I think it provided a huge impact.
Yeah, for sure. I've just been very curious, and thank you guys for answering that. The pandemic really showed how good you were at agile project planning, because it threw a huge curveball. We do have another question from one of our attendees. What advice would you give to someone that just started their healthcare career in a role that has never been done before, working on hospital project with little resources, when C-suite thought about just the end picture and not the necessary steps to get there?
Become a lawyer. No, it's really, look, we have an expression in the UK which is grasp the nettle. Really take it on board. The way that we set up the program that we have now was done with limited resources as well. It's about having the drive and the bravery to step out. In fact, when we gave the results of the first pathway we put in place, the chief medical officer looked at us across the table and said, I didn't really expect this to work. And so it's having the confidence and the bravery to carry on forward with it, and to start to break things up. It's an overused expression, but don't boil the ocean. Take one problem at a time, breach the barriers that are there, and start to expand upon that. Look at the whole picture, think synthetically about it, but break it down to bite-sized pieces. We're back to the cooking show, just so that you can start to understand it. And then don't be afraid to ask. Reach out to the people sat in the aircraft left and right at you. Get their input and environment from where they're from. So make sure that you cover all of the bases and work slowly and methodically through it, but think about everyone at once. Josh?
I would agree with that. Not much more to add. The only thing I would say is that, especially navigating in a new role, it's very difficult when you have a blank page in front of you. And so you're balancing the vision of your leader with the vision and your expectation of the role. And I think at some point, those two visions need to come together. And so the more conversations and the more questions that you can ask, I think that'll really help position you to be able to determine what is it that I need to do, how do I prioritize what I do, and then ultimately what are the measures of success that you would equate with this role.
Thank you, guys. Bernardo, you had something to add?
I was really raising my hand because I had a question. Meanwhile, students were thinking of some of the questions that I'm sure they have. But one idea is that being Advent Health such a large organization, such diverse organization, and being these issues, trying to involve everybody, as many people as you can, to transmit this emotion or this interest on improvement that you've been describing. But how can you do that by going from analyzing a clinical pathway and then bringing up to the organization and getting involved as many people as possible in the solution of that problem? So how can you select what to do and start getting everybody involved, even people that apparently are not involved in the direct treatment of the patient at the beginning, but of course their actions even before the patients come to the hospital, during the hospital, or after, have an impact on the solution of the problem. So what is a way that you've done that? Have you been able to successfully kind of bring like a critical mass of people involved, even if they're not the direct clinicians?
So it actually ties in with the question that Logan had put in on the chat as well, in some respects. The important thing with all of these is to be there. This is for people by people. And one of the things that we decided is that this is not at a distance. So with the 40-odd hospitals that we have throughout the company, this is about us being there, of being able to support each and every one, taking a standardized view and then localizing it. Being able to go and stand and look at what goes on and to approach it not in a process improvement route, but to look at the people that are there. So with Logan in the OR looking at waste, go and see. Don't just look at the numbers. Start to experience what goes on. That builds the faith and the confidence of the people that are working there. That can then be reinforced because they know you're going to be there, you're going to bring the information back. And more importantly, especially in healthcare, they then start to believe the data you're providing. Because the first thing that a clinician will do when you set up a spreadsheet of data is add the numbers up and say, you've got that wrong. Then you lose them forever. So the other part of this is building that trust and faith by really measuring twice and cutting once, looking at all of the aspects and making sure that it actually ties together. And then when you have that, is then getting the story out there. Data are numbers. Then start to progress it out as a story so that that can be understood throughout the organization as a whole and bring people into the story. The last part is to make sure that the glory is theirs. It's their success. They are doing it, and that'll enable the sustain element that's there. You're just the medium to make this function. And what you have to do is work twice as hard to make sure that your bosses understand the work that you've done, but the glory and the change, the successes, the wins go to the area that you're working on in its own right. Josh.
And again, not much to add there, but what I would say is that we were fortunate with our first few pathways, and those tended to be more high impact, high volume areas. And so a lot of the metrics, the process, the clinical care had already been under the microscope. And so being able to have high level physician experts, physician champions, nursing experts, nursing champions, being able to be actively involved in the improvement, the change, and that methodology really helped from a buy-in standpoint. And going back to Danny's kind of boiling water analogy, is that what that ended up doing was kind of sparking a grassroots kind of approach to where we now have many different providers, clinicians across many different specialties coming to us, asking about particular disease states or conditions or areas of opportunity that we can improve. And from a grassroots standpoint, I think Danny will often say that that you've changed the culture when it becomes ingrained in the work that's being done. And they say they've been doing it for 1 million years, when in fact it may have just been 8 years. And so that's really where that the culture has shifted, and we've seen that evolve from kind of the high impact, high volume areas that we initially tackled.
Thank you so much, Josh. Unfortunately, that was all the time we have for the questions section. I do want to, Marcus did put a very intriguing question in the chat that would be excellent. So what we might do is have Dr. Ramirez send that over to Danny and Josh, and that way he can share it with his class and you guys can all enjoy that, because that's a very good question, Marcus. But I do want to make sure that I share a lot of the stuff that Danny and Josh talked about tonight is in one of the books that Danny did co-write with another doctor about the transformative healthcare, those diagrams, all the things that you saw. So this is the book to definitely give it a check out if you're not already in Dr. Ramirez's class. And then of course, thank you to our guests, Danny, Josh. I knew it was going to be engaging, even though all we did was talk about sandwiches and vacuums. It was super interesting, and I loved every second of it. Thank you so much for taking the time. Dr. Bernardo, thank you so much for sharing your friends with us and your classroom. To our attendees, we absolutely love having you at our events. You can definitely obtain more information on our website and keep up to date and see more sessions just like this one on our YouTube channel, which this one is also being recorded live, and you'll be able to access it at a later time. Danny, Josh, thank you so much. We appreciate you coming.
No, thank you to everyone, and for the students and faculty that take the time to view this. And please, by all means, reach out to Dr. Ramirez with any questions or queries and any support that we can give. I will just say very quickly that, Marcus, the reason that we look carefully at the baby boomers in particular is that's me, and I want to design everything I can to be able to support me as we go forward. So that's the first teaser for you.
Yeah, well, and I'll also say that Danny is kind of our job security, so we have to make sure we get it right. So one of many.
All right, thank you all. We'll
Thank
see
you
you
very
next
much.
time. Have a great weekend.
Thank you.
Thank you.